Uneventful, minimally invasive glaucoma surgery, challenging post-op. A 48-year-old female referred to us as a case of POAG on combination AGM in both eyes since 2005 with no family history of glaucoma. Complaints of defective vision in the right eye for 3 months. Uncorrected visual acuity in the right eye was counting fingers at 3 meters, improving to 618 with RAPD and immature cataract. Intraocular pressure was 12 with AGM. Axial length was 25.69. Fundus examination showed a cupped ratio of 0.7 with inferior notch in the right eye. OCT RNFL right eye showed infratemporal thinning with corresponding superior visual field defects. The surgical plan for her in the right eye was phacoemulsification with MIGS. Among the various ab interno trabeculotomy, my preferred one is the Tenito microhook trabeculotomy. Tenito microhook is a specially designed hook with single blade, oblique tip surface and circular edge to cleave the trabecular meshwork. There are 3 models, bend version of left, right and straight. The appropriate positioning of patient's head, that is 30 to 40 degree away from the surgeon, and microscope, that is 30 to 40 degree inclined towards the surgeon, is the first and the foremost step of the procedure. After phacoemulsification, the AC is formed with high molecular weight viscoelastic. A Swan-Jacob lens is used to visualize. This is the angle left to incise the supranasal angle and the angle right to incise the infranasal angle. The hook is inserted into the anterior chamber through a 2.8 mm clear corneal incision to approach the nasal angle. It is inserted into the Schlemm's canal and moves circumferentially in the desired clock hours to incise the trabecular meshwork and the inner wall of Schlemm's canal. Here we can appreciate a white strip which represents the back wall of Schlemm's canal. Then the anterior chamber is washed and the wound is hydrated. This is 1 month post-op gonio CP on the left, showing trabeculotomy cleft and corresponding ASOCT on the right. Post-op, she had an exaggerated intraocular pressure rise of 60 mm of mercury at 1 week on topical dexamethasone. This needed both topical and systemic AGM with discontinuation of steroid at 4 weeks to bring down the IOP to 22. However, at 2 months post-op, minimal rebound iritis was seen and lotipred was started. Still, the IOP rose to 30 mm of mercury in 2 weeks' time. Discontinuing lotipred helped to stabilize the IOP at 10 mm of mercury with single topical AGM. Here, the post-op challenge was a severe steroid response. Literature review shows that the incidence of steroid response in MIGS is 1 in 8 patients. Young age and axial length of more than 25 were the significant predictors of steroid response as seen in our case. And it has already been known to us that on topical steroid, the IOP rises over 3 to 6 weeks and returns to normal within 2 weeks after discontinuing the steroids. And to conclude, MIGS is safe and efficacious in mild to moderate open-angle glaucoma with modest IOP lowering and minimal complications. Steroid response is to be kept in mind in post-MIGS with quiet eyes, especially in young patients, high myope, family history of glaucoma, pre-existing chronic open-angle glaucoma, and previous steroid response.